Hi, my name is Peter. I'm an emergency physician working in Stockholm, originally from Denmark, and today I want to talk with you about a journal club that I did recently for our residents in emergency medicine. And it's also more or less a introduction to journal clubbing and why it's important for emergency physicians to even do this. And I'm trying to, in the beginning of this small lecture with a journal club attached to it, to give some perspective to some of you who are new to journal clubs. It's not that common in Scandinavia. So that's why I've done this kind of as an example of as an example of how to do a journal club, how to read a paper, and more important, why it's important to do this and what's actually why we should or shouldn't be doing this, or because our time is precious and we have a lot of stuff that we could be doing instead of something that is less important. So is this something that's really important for us to do, and why? So I'm trying to answer those questions in this small lecture before the journal club, and then I'll go into the journal club with the study in mind. And it's no secret that my sub-interest in emergency medicine and in general is, or at least clinically, is emergency neurology and all subjects attached to that heading. And that's why I've chosen a topic close to my heart, which is minor strokes, and whether or not we should give thrombolytics or alteplase for this. All right. And sorry about my voice. If you can hear it, I'm maybe a little bit sore-throated, so I apologize for my voice being a bit rough. All right. As always, I like to post some links for inspiration and so that you can see what I'm talking about from a different perspective, or build your own kind of perspective on it. I would like to, when I'm talking about evidence-based medicine, I usually talk about it from a perspective of evidence-based medicine as one of several things that inform our decisions. And there are certainly some problems with evidence-based medicine, this tool that we use for applying evidence and for analyzing evidence. And it's important to kind of know about some of those things, and some of those are well summarized in some of these quotes here and references. And I'll show you more as well as we go along. If you want a great just overview of how to read articles and so on, you could check out First 10 EMs, resource pages for that. You could check out stuff like Sketchy EBM on YouTube. You could check out all the great FOMET pages that go through how to read papers. Ken Milne, the SGEM, Rebel EM, St. Emlyn's, there's so many. First 10 EM does a great job as well. And there's so many, so it's just it's not hard to find most of the find examples of how to do this, but it can be kind of daunting anyway. So we need we need to describe it in a way so that's not too daunting for us, because we need to be able to get something out of it. Not all of us want to be statisticians, or we need to it has to be down to earth. It has to be something that we can actually clinically use. So that's why I'll try to go through that, and I think First 10 EM does a good job about doing that as well. I'll talk about something called parachutes and RCTs, and here are some of the good references for that. And here are some of the good pages about how to learn to read evidence-based medicine. There's lots more, and some of the problems and caveats and so on and so forth. But you can check out these for definitely. And then here in the end, it was a bit botched here, but measuring, how to measure and why we measure stuff that we do, these last links are about that. and how we measure unmeasurables and so on. Okay. Okay, so on to the mini lecture here. So why do journal clubs at all? Why do we want to? Why is it important? Because I guess as an academic discipline, it's not something that has been done a lot in Scandinavia. So it really poses the questions of why should we introduce this now, or why should we begin to do this like broadly in emergency medicine or in any other department? Well, I guess there is the argument that reading articles and evaluating evidence is important. I think there is some merit to this argument, or a lot of merit, some would say, but the problem is that there's so many articles being published, right? Too many articles in any, like, even subfield of emergency medicine to actually be able to read it all. Several studies have been done on that. So it's not, I mean, and there's an argument to be made that maybe we as clinicians shouldn't be reading too much about this, like at least not interpreting it as it's really complex to interpret a lot of times, and maybe we shouldn't like do that too much. Maybe we should leave it up to experts. Then the counter argument is that, well, studies should always be interpreted by clinicians, or at least someone who knows about the clinical like setting, and to be able to apply that knowledge. So there's this kind of gap between actually extrapolating and doing studies, and extrapolating the data and actually interpreting it and then applying it. And I don't think the jury's still out whether clinicians like me and you should be reading this stuff in that extent, in such a big extent, and whether it should be epidemiologists who just summarize it for us and then gives us the gist of it. No matter what, one of the big reasons why we probably should be reading articles still right now is that guidelines don't really inform us, and a lot of the questions that come up with practice with patients, it doesn't really, like, if a patient asks about a certain thing about their specific condition, then we need to be able to find a study or find a guideline, but the guidelines usually don't answer in a way that we can use for the patients. They don't answer like the numbers needed to treat or numbers needed to harm to inform the patient in a good way. They usually just give us recommendations, and then we have to as clinicians know whether the patient applies to that group. But usually the guidelines don't really give us any information about what kind of group they're talking about, or at least not in a very specific way, so that they have like a kind of like inclusion criteria for that specific recommendation. It's at least is really rare, and a lot of people has criticized this, like Jerome Hoffman, Justin Morgenstern in his blogs about guidelines, John Ioannidis, Iona Heath, and so on and so forth. So guidelines are controversial, and it's definitely something that we would like to. There's the concept of a guideline is really good, but there's definitely something about guidelines in its current form that is both like highly simplistic, so that it's good if you're not an expert in the field to like kind of get an overview, but if you're an expert in the field or you have a specific question for a specific patient, it's kind of hard to get information from a lot of the guidelines. What would be nice would be guidelines written in a way so that it's more like clinically useful, like what are the likelihood ratios, what are the numbers needed to treat, numbers needed to harm. And also it would be nice if guidelines are not written with such a high conflict of interest problem. Again, Jerome Hoffman and Justin Morgenstern have written at length about these things, so you can check out that argument otherwise elsewhere. But there's an argument that we should be reading articles kind of to know some of the more important stuff, and we could like go outside of outside of guidelines in some cases. But I think that may be the lesser of the arguments. I think the most important thing for why we should be reading why we should be doing journal clubs, is the more philosophical and maybe fluffy thing about it, that we should be good critical thinkers, and journal clubs uh, makes us better critical thinkers. And um, I think it gives us a perspective on why it's important to do something, and it gives us in a perspective of kind of the weight of a lot of the treatments that we're using, because most of them are not that important, as we'll get to in a little while. There's so many more other things that are much more important than giving aspirin or whatever, at least if you look at it from numbers needed to treat perspectives. So I think that's a much more important important value taken from journal clubs. And specifically for emergency physicians, we talk about opportunity cost for instance, in the emergency room. If I look at the guidelines for upper GI bleed, then and I've asked the surgeons, then usually they'll just say PPIs, for instance. And if we read the papers on PPIs, we know that there's no benefit for PPIs, at least not any high evidence at all. And the small evidence that there may be is from retrospective, really small studies that are, and it's not even good outcomes. It's like so evidence-wise, there's not a lot of things to be had there. And I'm not saying that evidence is the only thing, as I'll come into later on, but more to inform us that okay, someone says to us, "Well, give PPIs," and that's okay. I will give PPIs, but as an emergency physician, I am also aware of opportunity cost. And even though it's not harmful to give PPIs, probably in the emergency setting, it's definitely something that you spend a line. Like, I don't want to spend all of my lines on useless stuff. So it's something that I can under prioritize instead of giving blood. So this, like, how to prioritize is something that we need to know as emergency physicians, and for us to be able to do that, an important thing is to know the weight of different stuff. And oftentimes the guidelines don't inform us about that. That's something we have to get from reading literature, getting evidence, like distilled from like FOMED resources, stuff like that. At least until guidelines get their stuff together and write what we try to do in foam form, like in FOMED form and on the internet. So we need to kind of until they improve, we need to do this on our own. And I don't think they will be improving anytime soon. Um, but we'll see about that. Okay, so my formula for going through a journal club and through a paper in general is first of all, we need to have some kind of, this is what we call a Bayesian way of doing it. And it's inspired by the homepage EBM 2.0 by Anand Senthi. And you can hear about that in Justin Morgenstern and Broomdog's podcast, where they talk with Anand Senthi. And Anand Senthi has done a great YouTube video about his entire concept as well. But in general, it's not too far off most people's like way of going through it. But I think the background, the way that you apply Bayesian theory to it is really important. So the study itself is in the middle. But before we go into the study, we need to kind of know where it fits in the context. What is the pretest probability? If we think of the study and the result of the study as a test, then we need to be informed about the pretest probability before. Like, what is the context? And the context is, if we know about the evidence, like how many papers have been published, either in its own field. So, for instance, in this field about alteplase for stroke, in minor strokes with NIHSS below 5, as we'll be talking about, then there might be some studies out there specifically on that, but I can broaden my net and talk about the evidence on alteplase for all strokes, because that does apply somewhat. And then I can talk about, well, giving alteplase to anything or any thrombolytics to anything, and how that helps, how fields that are tangential to what I'm talking about, what we're hearing about right now, how good the evidence is there. And another example is tranexamic acid. Okay, I might be interested in tranexamic acid in trauma, but my pretest probability, if a new study comes along, is informed by how good the tranexamic acid is in trauma specifically, but also somewhat how good it is in other fields. And if you want to develop this argument even further, you should check out the journal jam from EM cases about tranexamic acid with Ken Milne and Justin Morgenstern. It's great, and they'll talk through why this pretest probability assessment is so important. And I'll talk a bit more about it. Then also, that's kind of the evidence. Then we also want to know what kind of, is it even bioplausible? Does it make sense from our paradigm, what we do right now, how we understand the body? Does this make sense? And an example of this for in our case here would be, if I thrombolize someone, then I guess there's if I thrombolize a clot, then it will, it's a clot busting drug. That does make sense. The stroke in the brain is a clot. If I give something that removes the clot, a blood thinner, then that is plausible, that could help, right? And this bioplausibility may be strengthened by some animal studies or other studies where not in human studies, or not in animal studies at all, but more like in a laboratory, on a pharmacological level. Does it make sense? And this is what we will call a bioplausibility or mechanistic argument, and they are important. It has to make sense, right? But and as we'll come to later, sometimes that's not all that matters, but sometimes we can change our paradigm if there's evidence, but it's not really how we thought the body would work. And sometimes it's just totally wrong because we did the studies wrong, and the bioplausibility thing was right all along. But we'll talk more about that. So it's the evidence, and then how likely is it from a mechanistically physiological standpoint that this will work. Then we have kind of a pretest probability before heading into the study, and the study could be viewed as a test, like the likelihood ratio, and then we'll talk about how to go through the studies in a little while. But in general, if we look at it, this is an abstract from the study that we're going to be looking at. And oftentimes when we read through a study, it's important to know where to find the information, because if you're new to reading studies, then you might be reading it from cover to cover. That's definitely not a good way to read through studies, because you will just fall asleep after a few of them. Even experts will say that they fall asleep doing that. So if you're new to a field of study, then it's quite good to read the introductions, because then you kind of get a scoping, a quick and dirty review of what is the field like, and why is this important. The last sentence in the introduction is usually why, what they're going to do in this particular study. And then usually people jump over the method section and go to the discussion, and the discussion is usually the subjective interpretation of the results. So in the first line or two of the discussion, they'll mention their conclusion, and then they'll discuss strengths and limits, and then they will come with a final conclusion on all of it in the conclusion section. But the most important section for all of us actually would be the method section. If you kind of know a field of study, then the method section is probably the only important thing to actually look at. The methods and then the results, right? If the methods, as we'll come to, are good, then we're interested in the study. But if the methods are not good, then we can just discard the study before actually reading it and save ourselves the time. Because even though we may be interested in the conclusion, oh, it seems like, oh, this is a really good drug for me in the emergency department because it helps. Because the people who have made the study says that. But when I read their methods, it's not good methods. So I don't believe in the results, and therefore I don't believe in their conclusion. And sometimes especially if there's big conflicts of interest, either from pharmacological payment of the study, or if there is some kind of other sponsorship, or if there's some kind of academic interest from the study participants, then sometimes there's a high discrepancy between the results and the conclusions, because the way that they cherry pick the results or cherry pick the p-values, or the outcomes, as we will not go too much into detail about p-hacking, but just saying, read up on Ioannidis' papers and videos about this, and you will see that there are ways to manipulate studies, either consciously or subconsciously. Probably most often subconsciously, but sometimes consciously. And there's a highly, we need to select data, and some in that selection process we use our ethics oftentimes, right? And if we're trying to, if everything is published only if it's positive studies, then I know if my salary depends on that, then I will consciously, or probably more likely subconsciously, go towards that positive result instead of the null hypothesis, right? Okay. Then once you've analyzed the study, we usually do it with a PICOS, just to analyze what are the essential data, and then you look at the results, and then we kind of do what we call a checklist to check for specific words like blinding, allocation, and so on and so forth, and see if you could control F that, and then you'll see all of the words, and then you'll see if it's there or not. And then you go back to the reality, and you kind of okay, so how big is the likelihood ratio here, and what is my post-test probability after this study? And is it a big likelihood ratio? Is it a big arrow up, or is it a small arrow up, depending on how positive this study is and how good the methods are, and so on and so forth. Okay. And the Fagans nomogram, I've done it in a lot of studies, in a lot of videos, and in general, it's just, our studies, our pretest probability will be somewhere around, depending on if we're a skeptic. So it's not only informed by evidence and by plausibility, it's also our feelings towards this. So I might be a skeptic, or I might be a proponent of something. And then a study, if it's positive, above 1, it's very positive, then even the skeptics will be, oh, this is probably good. If it's maybe 500, that's really unlikely, but because rarely one study changes anything. And we should be aware, if a small study has a really big impact, then it's probably a wrong study, or the wrong number, or it's much less than it's supposed to be, or it's much, much less, right? But if it's, well, let's say more realistic number, if we have a low pretest probability, we're a skeptic of this field before going in, even with our evidence and bioplausibility arguments, and maybe the study is quite positive, maybe 20 or 10, a believable amount, then we will still be skeptical, but more convinced than before. If we are logical, at least we can definitely be illogical about this as well. But if we agree on the interpretation of the study, then that will be the case. If we are proponents and it's positive, then we will still be proponents, right? But if it's and the same thing if it's negative, if we were proponents and it's a really good study but it's negative, then we are not discouraged totally, but we are much less than before. Okay. So why are we even doing studies? Why is that even important? Why do we need to do studies in medicine in general? And I mean, this is not a big research into all of this, but I just wanted to go through this quickly because it's important for our new journal clubbers to kind of know this in perspective. And it's important to ask these questions. So why am I do studies? Well, if we look at these arrows to begin with here, then most of our therapies that we do, are not that big, right? They don't have that much of an impact. We might think that they do, but oftentimes we don't. They really don't. So if you look at this, like in general, there are three therapies. Either there are small harm, large benefit, relatively or comparatively large benefit, or there's a small harm, small benefit, or there's a large harm, small benefit. These are the ones that we might consider using. This one would probably be the ones that we don't use. But if you look at the quote here from Goethe, it kind of depends on what kind of harm this is. If this is only mild nausea, and this is not having a stroke, for instance, then this looks like a good therapy. So it's important, like it's not only the amount of harm, it's also like what quality of harm is it, of course. So it has to be, we talk about patient-oriented outcomes here, like all the benefits also has to be like patient-oriented outcomes, like so it has to be mortality or morbidity. We need big studies for actually testing that. So oftentimes we're testing what you call surrogate endpoints, and surrogate endpoints are it's like instead of for diabetes, instead of testing mortality and morbidity, what means something for the patient, we test HbA1c, and we think that it correlates somewhat to mortality and morbidity or severity of diabetes. That's the hypothesis. But when we do studies on surrogate outcomes, when Vinay Prasad and John Ioannidis and all these meta researchers do studies on it, it seems like it's not really holding up. Most of the time, surrogate outcomes don't causally correlate with the patient-oriented outcome that we think. And the patient don't really care if their ABHC is high. That doesn't represent anything meaningful for them. Only if it means that they will die more, or they will get more of the stuff that they don't want, like blindness or strokes and so on. If it doesn't represent that, then the A1C could be as high as they want. It doesn't matter. That's what we call a surrogate outcome, or Ken Milne usually calls it a monitor-oriented outcome, or a lab-oriented outcome, a LU, or a and so on. What we want is a POO, a patient-oriented outcome, which usually is mortality or morbidity. And it's important that it's all-cause mortality, not, well, if you want a discussion about that, then look up first 10 EM's discussion on the CRASH 3 study, because there are some arguments to be had from intelligent people, who would say that disease-specific mortality is important, or the one that we should go with. But I think the argument is stronger for all-cause mortality, because I don't care if I die from, like, if I take the example with stroke again, I don't care if I die from stroke or I care from complications to the stroke. But if I'm only measuring stroke mortality, like bleeding mortality, and I'm not measuring all of the other mortality like related to that, but maybe not measured, then that's a problem, right? So I want to know all the death. I don't care what I don't care if I die from a bleed. If I die from something else, then it's as important. So and of course we have to have a control group to see that that we're not. It's not just because of their age that they're dying from something else, or some kind of complication that is not related to the therapy, of course. But all-cause mortality seems to be the way to go, even though it's harder to measure and it takes much more people. Okay, but most things in medicine, notice that these arrows are not that long. And if I take the example of ASA here, acetylic salicylic acid, or aspirin, for stroke prevention, then the numbers in industry, you might think like, oh, it's really important to give it's really important to give ASA. But most things that we give has an NNT, a numbers needed to treat, of pretty high, and that's pretty good. Like 80, if we give 80 patients this drug, then we will prevent one death. That's huge on a population scale. But for the specific patient in front of me, that's a hard sell, or sometimes a hard sell, especially if they're 90 and they don't have many years to live and so on. And most of the studies are not done on that population in specific. So, and there's huge problem with numbers needed to treat, as well as all other outcomes measures. So we need to be looking at this from different angles, and it's hugely simplified. But in general, it does paint a picture of what I'm trying to say, that a lot of the effect sizes in medicine are quite small. Of course, when you add it together, you give ASA, you give blood pressure medication, you give statins, and so on. Then the numbers to treat becomes less for that like triplet of drugs. But it's just important to know, especially as us emergency physicians, we kind of need to know how we need to treat the things that are most important, like at first. And at the other hand, you have the numbers needed to harm, of course, here. Okay. And the thing is, we need to be better at this. This is a study from meta-analysis from systematic review, from Tammy Hoffman, saying like the conclusion is almost legendary by now, that we in general underestimate the harms and the benefits. Our clinicians more often underestimated rather than overestimated harms, and overestimated rather than underestimated benefits. And for patients, I think there's another study that says that's the other way around. They usually overestimate. Maybe not the other way around, but we're kind of forget that. But we're kind of as clinicians more reluctant to believe in our own hype. And I've done this lecture on compassionate care before, and like how important that is. It's unmeasurable in a lot of ways, but it's really, really important, I think. Especially compared to some of these like numbers. These are also important. This is part of what we do, but we need to like put it in perspective of how much it weighs, like in comparison to other things. Okay. Yeah, and just a quote from Ken Mill about the NNT, like the NNT, the homepage is really good, and I really like that. But the NNT as a concept sometimes has problems, and you can read on about this, like as with every other measure, as we say, like there are problems with the NNT if used in isolation. So we need to look at other outcome measures, right? One of the great conceptual difficulties of summary statistics like NNT is the implication of certainty. A major strength of the NNT is its simplicity, making a complex research easier to understand. A weakness, however, is also its simplicity, because it can hide the complexity of research. So we should use these NNTs, and it's good to like compare them. But as we say with like for instance with Gutsch's quote from before, it's kind of depends on what is important for the patient actually. If sometimes the harms that are important to one patient is not important to another one, and therefore the harm benefit ratio sometimes is a misleading concept, especially if we use numbers. So we need to kind of know the numbers, and we also need to ask the patient of what is important to them. But overall, we can sometimes use NNT and numbers needed to harm, because none of us wants strokes, none of us wants bleedings, right? So that's kind of an outcome measure that is important. But we probably need to do more studies on patients on what's actually important for them. And there's been a talk about that for a long time, and a discussion about that. And the reason why I kind of, it may be obvious to you, but the reason why like we even do studies is because like most things in medicine are not parachutes. And what do I mean by that? Well, the parachute argument from like the BMJ, legendary BMJ series by now, about parachutes and studies. Like, so most things in medicine are not parachutes, meaning that it's not like if I jumped out of a plane and I didn't use a parachute, I'm doubtful that I will die almost certainly, right? And the treatment, meaning the parachute, will almost certainly save me, right? There's no reason to do an RCT study on that, we don't want 10 people to jump out of a plane and with and without a without a parachute, and see who survives, because there will be 10 non-survivors and there will be like 10 survivors if you can use your parachute probably, right? So that's what you call the parachute argument, and we sometimes overestimate what are parachutes in medicine. A lot of the stuff that we do don't really work, and we think of it as parachutes. And oftentimes we chastise our colleagues for not doing. Oh, they weren't doing this. They didn't do this. That's horrible. We didn't give like acetylic salicylic acid to this patient with stroke within 24 hours. Well, that is important. We shouldn't forget that. But complicated things are complicated, and oftentimes it's complex decisions. Maybe they're bleeding, maybe there are other factors, maybe they were older than the population, so on and so forth. Or maybe we just forgot or under prioritized it because of other things. And it's okay sometimes to do that, especially when we know kind of the how important, or should I say little importance, the acetylic salicylic acid has on an individual level. On a population level, huge importance, but on the individual level, numbers need to treat around 80 to 90. That's not that good. And if you want even more complexity on that, Vinay Prasad made these studies on aspirin. I think it was I can't remember. I think it was for heart failure. For angina or ischemic heart disease. He did a rerun of some of the studies, or analysis of the reruns of the studies, and it seems like he has an argument that we should probably be doing new studies every 20 or 30 years on the major things that we're doing, because on the new studies the aspirin didn't look that good. That might have been because of this change in lifestyle, that we're becoming more healthy, and therefore the aspirin effect is less important. There's a lot of reasons to be had, arguments to be made about these things, but you can check out those articles about aspirin and whether we should update, rewrite the evidence or redo the evidence every 20 or 30 years. There's even this, and then there's this reproductive crisis, right? We can't reproduce the evidence that we thought was really hardcore evidence, and that's a separate question that I've addressed in several videos and podcasts, but I won't go into that here. But the parachute argument. So, are there any parachutes? What are the things that we shouldn't test in medicine? What are some examples of parachutes? Well, Glashow from Bond University in Australia, who's one of these evidence-based people, he's done you can check out his recommended dose podcasts interview where he's interviewed about a lot of these things, and he's a great guy to listen to. And he did this just overview study in 2007 where he had some historical examples of dramatic effects of treatments in medicine. So, for instance, we don't want to do a randomized controlled trial of insulin and diabetes. We know that it works. We can see it with our eyes when we see it. And of course, we can sometimes be fooled by our eyes. That's the problem with a lot of the arguments that we're having here, right? Some would argue something is a parachute because I've seen it with my own eyes. But when we do, so that's the problem sometimes. But with insulin, it's undeniably true with diabetes type 1, right? There's even that story about that kind of humbling story where they didn't patent it in the way that we do today. They made it free so that people wouldn't be able to make money off something that is so life-saving. There's nuance to that story as well, but I think it's a Canadian physician and orthopedic surgeon, I think even, who made the insulin, and that story is worth taking a look at. There are other ones, like blood transfusion for severe hemorrhagic shock. Doesn't mean that we don't, Justin Morgenstern just came out with a big post on major hemorrhage protocols, major transfusion protocols, and why they probably aren't that well evidence-based. But if you have someone who's insanguinating before you need blood, right? But the proportions are difficult to measure though, and so on and so forth all the way down here. And most of these are like really hardcore physiological arguments to be had, and where we don't need this, and why we don't need it. That's where the hard part is. Which ones are so obvious that we don't need a parachute, and they don't need a study on it. And the argument is like most things that we think are parachutes probably aren't. So if we cannot, like most things in medicine are, like when we do a study on something, it's because we know that the benefits are quite small. And the more patients that we need to enroll in that study with a power calculation, the smaller the potential benefits are, right? That's just facts, right? That's how it is. Because if we need to find a big benefit, we don't need too many people in that study. If we need to find a small benefit, we need lots of people. So the larger the study, the smaller the benefit we're trying to find. That's why RCTs are really important to do when we need to find small things. It's really like, because there's so much bias that can be introduced here. So we have these two ways of studying things. We have observational studies, and we have experimental studies, like which would be RCTs, right? Those are the big two groups of descriptive studies, right? And then you have a group of narrative studies, which are also important, but nothing that we'll go through here. But and the observational study, where we look at something where something has been done, and we look at it retrospectively, has its place. And I'll show you when it has its place, but we shouldn't draw too many conclusions from those, at least not say that it's causal. Vinay Prasad has made arguments about that as well. And we should not, unless there's specific circumstances that in observational studies, like a really high quality observational study, you should probably be really careful of saying that it's true or it's causal what observational studies find. Because if I look at a data set, then I will be able to find a data set that looked at like, oh, they thrombolized a lot of people. Then why did they choose those specific people? There's what you call selection bias, and that group of people might be totally different than the other group of people that didn't really receive it, not because of the treatment being the only variable, but because they were somewhat sicker, or there were some kind of and that's the, like Vinay Prasad has made talk about this at length about COVID and so on. So you can check out his videos for a deeper argument about observational studies. He has an entire video on it that I linked to in the references. So it's really important arguments, and but there is a place for observational studies. But most things, when we want to find these small benefits or smallish benefits, we need to do RCTs, and the bigger they are, the smaller the benefits, right? Or the smaller benefits we think, the bigger the RCTs need to be, right? And that's also why a lot of things in emergency medicine, like really dangerous stuff, like are really rare. And we are kind of reliant on the observational studies because the events, like seeing a subarachnoid hemorrhage in a specific emergency department, is really rare. Something like happens once a year, twice a year, or maybe a few more times. But in general, it's not and you can't run a study for that long and only have two events. So you need, like in most of emergency medicine, a lot of it is observational data because it's too rare. Like the needles in the haystacks that we're trying to find are too rare. It's just something to be aware of. Okay, this is from Vinay Prasad, when to do randomized controlled trials. And so things out here, like this is like the net effect. If there's no net effect at all, then we shouldn't, like then we could do trials. But here are the parachute, like wearing a parachute, almost always life-saving. We should probably not be doing trials here at all. And in the same way, if it's only harmful, like shooting someone in the face or in vital organs, or pushing someone off a cliff, there's this great ENT doctor from Sweden who's made he made a career out of making kind of comedy medical videos and songs, and he's made this video about, well, this RCT where they try to push people outside of windows in the orthopedic department and see who survives. It sounds kind of rough, but it's really funny. And that's the exact thing. They don't need to do an RCT on those things because they're obviously something that will be painful and horrible to the patient, right? This is something that they kind of studied. We were talking Nuremberg process things over here. So, of course, that is not something, or Tuskegee and so on. This is not something that we want to do experimental studies on. That's why also we don't have, like, this is also where we don't have. This is where we get like things that are primarily harmful to patients, like smoking or teratogenic things in pregnancy. Like, this is something that we need to know something about from observational studies, because we don't want ethically to apply pain or something that is obviously harmful to anyone, right? And we can talk about the ethics on this study that we're going to talk about today as well. But this is really important. Like, harmful things, primarily harmful things. That's why we can't study. And there are some things, like if we map out all the things that we want to study, there are lots of things that we can study because it's in this category. It's in this category over here, or stuff that we probably will never get the answer to fully because it's unethical to study it. So where is randomized controlled trials? And it's, if there's net positive effect, then it's over here. And there needs to be what you call equipoise, right? There needs to be a sensible amount of doubt about whether treatment A or treatment B is good. And how do we establish equipoise? Well, again, check out Vinay Prasad's video on that specifically. It's kind of a hard topic, but in general, if I don't know which treatment is the best, in short, then there's equipoise. And a lot of the equipoise argument in favor of a lot of the things that we do just because we've done it always is because it's like, oh, it's tried and true. But then once we do studies on it, what Vinay Prasad calls medical reversal sometimes, then we find out, oh, it was not good. It was actually bad. So an example I sometimes put out is the one of the most painful procedures in emergency medicine when we look at when we ask patients in studies, that is the NG tube. Putting down a nasogastric tube into someone's throat through the nose for either treatment purposes or diagnostic purposes, in upper GI bleeds, or especially in small bowel obstruction, is something that is, and I'll choose my words carefully here, it's something without too much evidence. There has been, I did a review on that earlier this year. I haven't published that though, but there's something like 3 or 4 studies on it, all retrospective, all really small. So there are some evidence, but like, I'm not saying that it's wrong, but the studies that are not good enough to say that it's neither good or wrong. But the studies that are not in favor; they are against it. But they're probably not done good enough so that we can actually eliminate it. So we need a good, decent RCT on this. That's the area where we really need an RCT, right? And so that if that RCT comes out, if it's shown to be harmful for patients, then that's a problem, right? So that would be a medical reversal. We've done something for a long time, and then we reverse it by doing that. A true medical reversal would be something that is we've done would be like cooling in cardiac arrest, right? Cooling after cardiac arrest. That is, there was two big RCTs, or two, so not big, but 2 RCTs in the beginning of the 21st century, around 2002, I think, and 2004. There were 2 positive studies, and they were positive, and then then this practice of TTM, targeted temperature management, was implemented over It seemed like overnight, but like over a short period of time. And then it's taken a long time to actually roll that back to, like, once the horse is out of the barn, it's kind of hard to not do it. And then you have to like establish equipoise to even do that RCT. If you cannot just do the RCT because now it's beneficial. It seems to be beneficial, and you can't do a RCT on the contrary, right? So that you have to do an RCT or observational study that kind of seeds doubt, and then then after that you can kind of, okay, maybe we should do a RCT on something like temperatures of down to 34, and then, oh, that doesn't work. Okay, so you have to come at it on different areas before actually being able to do the primary RCT that could do, like, to challenge the first ones. Again, the TTM versus no TTM. That study hasn't been done yet, but it's very nearly we're really nearly there where we have equipoise, and then we can do that study. That's a problem with implementing things too early. We shouldn't wait too long either, but we shouldn't implement them too early, because once they're implemented, then there's no equipoise anymore, and then we can't study it anymore, because then we are in, at least from a public view, ethical standpoint, we're in the it's net positive, which probably often almost always is wrong. So our entire ethics about this or our entire way of doing these things are wrong, because we're pushed to do positive studies. There's publication bias, there's p-hacking, and so on. So we have a huge amount of publication reproduction crisis problem here. So we should be more cautious, but we aren't, because pharmacological and universities, like pharmacological companies and universities, need to publish. It's not their fault. They're not evil. It's the system that we created, and we need better regulation of this. That's the argument of Ben Goldacre. Okay, but RCTs are from these, like, small benefit things, as we'll talk about. Okay, this is one of my favorite things to talk about here. And this is one of the last slides in this mini lecture before going into the RCT, or into this study. So, and this is where I really think this is important, like why this more philosophical stuff is really important, because once the patient sits in front of you and you are asked, like, okay, you have a patient with you have a concert pianist now who has a hand that is weak. He comes in within 1.5 hours from his symptom onset, and he asks, and you says, well, alteplase is something that we can give. We should thrombolyze you, and he asks why. Then you can argue in different ways, like, how do you know, is actually what he asks. How do you know? Well, you can ask, like, tradition-wise, we've always done this. If you're like me, how you came out of med school after alteplase was a thing, then I've always done this. We've always done this. This is the tradition of the hospital. We do this. That's not a strong argument, though. At least not if it's not, like, there's some experience in there as well. So sometimes it's just tradition. And then you can say, well, this is a blood thinner. You have a clot. Or I clinically think that you have a clot. So if we'll do the scan, if there's no bleed, then we'll do a clot busting treatment, and then if that probably will remove it. So it makes sense, right? That's mechanistically the mechanistic argument, and the mechanistic argument is good. But it's oftentimes, the body is much more complex than we think, especially in medicine as opposed to orthopedic surgery, where, like, when you talk about broken bones, even though there's complexity there as well, it's much more it's more predictable in a mechanistic way than medicine is, because there's too many butterflies effects in medicine in the complex body. And a lot of the things we think we know, especially in the healthy body, it doesn't apply to the specific patient in front of us, and especially not when they're sick, and so on and so forth. The clot that you have may have been an old clot from the heart, and if it's an old clot, then it's not, like, too prone to be block busted by an alteplase, right? So it's there. so on and so forth, right? So that's and Ken Milne usually talks about, for 200 years ago there was this argument that, well, like we had the Galen bodily fluids things, that's what the ruling paradigm, and we need to put off blood, like we need to bloodlet people in this situation. That would be a probable mistake, we think today, but our paradigm today might be discouraged only 10 years or 20 years from now. So, and then there's another argument in mechanistic to be made that, well, yes, that might be true, but we're getting better and better at actually getting mechanistics right, because now we have better methods and so on. I think maybe that is true, but at least it's hard to argue that the mechanistic argument is not flawed. It is. And I'm not saying that's bad. We should definitely, like in all situations, like there's definitely different situations where mechanistic argument is really good. On other times, it's better to use experience and evidence-based medicine. And oftentimes, it's a spectrum. We need to use all of these tools. I see them as tools of knowledge, not one rules out the other. Especially when you have a patient in the emergency room, or you have someone who's really in a bad way. We need to use our physiology, our mechanistics, to argue which treatment to use best. But we need to be humble about it as well, because we know that if we're giving one vasopressor, this vasopressor would be the best one to give right now. Well, maybe from a pharmacokinetic standpoint and so on, but in reality, when I give it now, it doesn't work. So, is my hypothesis wrong, or is it just too complex? So that's why the emergency room is an iterative process. We kind of inform ourselves from evidence and the mechanistic argument of how we think the physiology is working right now, maybe informed by PICOS and other measures, and we try to do something and see if that doing something actually works. If that doesn't work, then we have to try another thing, and if that doesn't work either, then we have to reinterpret our hypothesis instead of just saying that we're right about the physiology. It must be like this, right? So we need to tread humbly, but with confidence. That's kind of a balance and a yin-yang thing, but that's what we have to do. And when it comes to like, this is where the bioplausibility thing comes in as well here. Experience is another way of telling this patient, I've seen lots of people being thrombolized, and it usually works. And that's not like, there's an argument to be had that most people being thrombolized, if they become better right away, then that's not good. Then that's usually because, then you thrombolized a mimic or or a CIA that would have become better on their own. Thrombolytics usually work, but if they work over minutes to hours, not like instantly like that. Or that's like Justin Morganson's argument, at least. Then you have systematic evidence, and that's why there's a really important thing about experience. It's really important to have experience and to be experts and know about mechanistics, but it's flawed as well. So we need to kind of have some kind of systematic evidence as well, and that's in the current form is the last 30 or 40 years has been evidence-based medicine, which it's important to know it's a brand. It's Gordon Guyatt and David Sackett who made this brand, and this brand is somewhat overhyped and has been overbloated, I think, to the point where you cannot criticize it and that's why I think it's important to mention these things to balance it out. It's a really important tool, but there are definitely critical things to be criticized about it. So, and you can check that out here. I don't want to go into details about that right now, but in general, it's populations, and we want to treat the patient in front of us, and that's a problem. That's one of the main problems about it. And it doesn't, like the evidence triad is usually like David Sackett's triad is evidence-based medicine is defined by deciding the patient's treatment from the best external evidence that's reading evidence and interpreting it, right? Doing clinical judgment, like judging this clinical situation, being an expert clinician and so on, and then sharing the patient's values and seeing what is like shared decision making, what does the patient want. But oftentimes the critics of EBM will say that there's too much emphasis on this. Also, critics would say that the entire system and the regulation has been hijacked. That's a different argument, but it's a true argument, I think. And most wouldn't agree. The reproductivity crisis that is in medicine is a problem. Yeah. Okay, but so here today we're only going to focus on this particular way of knowing. With this patient, we're going to try to use the evidence and analyze the evidence. That is the context that journal clubbing fits into. It doesn't help with this. It doesn't help with the mechanistics. It helps with this, the best external evidence. And it's important to know that we have a wide range of knowing epistemology. And if you want to know more about that, check out this link about epistemology and on the Grand Rounds podcast, also Bedside Round podcast. Okay, and just to hammer home, these, except for tradition, mechanistic argument, experience, and EBM, they are good for different reasons, and they are not below each other. They are something to be used like in different situations, and most times all of them has to be used to find an argument for whether or not to treat or not. Okay, so that's a mini lecture of an hour here. Now we'll go into the trial and do the journal club. And this is just a quick journal club. I won't go into all the details because I think it's less important actually. But just go into like do it systematically, but in a way so that I think you can do it at home, and more or less use it as an example of why how to do a journal club and how to go through it. So that's why I won't go too much into details, but more like why this is an important thing to do. And I'll show you this as an example. So this is the trial that we're going to use is Cathry. Cathry et al. Called the PRISMS trial. Effect of alteplase versus aspirin on functional outcomes for patients with acute ischemic strokes and minor non-disabling neurological deficits. And it's always good to have a case to frame it. So we have this 55-year-old man who was a concert pianist, who 1.5 hour ago suddenly had a weak hand on the right side. What's the management of this patient, and what is your information for this patient? Okay, so we'll go into, before going into the study, as I said, we want to know something about the background to inform our pretest probability. What studies have been done so far in the field? Are there any tangential fields about on thrombolysis or streptokinase or ACS and so on? And what is the bioplausibility? And I'll just go through the studies so far, and the rest I'll pinpoint you to something else. Okay, so when I talk, I have a background in neurology as well. I was never a resident, but I've worked in neurology at a resident level for 2.5 years in different hospitals, and I loved it. And I really, that's where my passion lies within is one of my passions, at least within emergency neurology in the emergency department. And when I talk to my neurological colleagues, there is this controversy, of course, in medicine. This is from an EBM perspective, pulmonary embolism and stroke are two of the most controversial topics in emergency medicine. And there's a huge gap between the neurologists who believe thrombolysis, almost all of them believe thrombolysis is at least something that works, and we in emergency medicine oftentimes informed by the more or less informed by foam, free online access medical education, are more skeptical. And it's important to how could this be that two really highly educated groups are so different in a specific point? And then, well, when we ask a neurologist, usually I think they see a lot of the patients right in front of them, right? They want to so they might have the experience or think that they have the experience where they've seen patients change in front of their eyes, and there's a counter argument that I just talked about before, that the ones that change in front of your eyes within minutes are probably not strokes, they're probably mimics. There's another argument that, well, the bleeding in strokes in mimics is 1 in 500, whereas if you have a stroke, it's maybe 1 in 12. So if you do traumatize someone and it turns out to be a mimic, it's not that harmful. It's at least very, very low risk. There is this argument that I guess there's a huge uncertainty in medicine and also in evidence-based medicine, and maybe we haven't found the group, and I'll rather just treat the patient with thrombolysis or at least offer the patient thrombolysis, because most of the neurologists are aware that it's not a miracle cure on average. So when they inform patients, they will say that there is this treatment that has some harms, but I really strongly suggest that we give you this to you. So, and then most patients will I think that is a strong argument. Most patients will say, "Oh, this actually helps," if I will take the risk. So that I know that I did everything that I could, right? As long as they're informed about everything that they can do, is maybe only a benefit of 1 in 10, and an increase of 1 point in the MRS score, right? But that's important if it's from 2 to 1. Okay. So that may be I'm just like guessing here, but I'm maybe informed guessing, but that may be why the neurologists are in another fields when it comes to like believing in the like alteplase as a good drug, and usually giving it a level A recommendation all over the world, right, within 3 hours at least. And in emergency medicine, mainly led by Jerome Hoffman, Ken Milne, Justin Morgenstern, and Ryan Radecki, and others as well. There's this summarization here about if we I guess the argument is, if we believe that in the evidence-based movement, if we believe that RCTs are important, then it's hard to argue why we're still so invested in alteplase and are not doing like studies to kind of find out whether it works or not, because these are all the studies of alteplase, right? You have all the yellow ones; these are the ones that are neutral, like no results. The red ones are the ones that are harmful. And there are nuances to all of this. If you want to read like Justin Morgenstern on Journal Jam or on his own homepage, he's made like a review of all of these studies in one block, so you can check that out. But the ones that are positive are the NINS-2 trial and the ECAS-3 trial. And so that's the background here. There are 2 positive studies. There are Jerome Hoffman made a reanalysis of this NINS trial, and it turned out in that reanalysis it was negative. It has been reanalyzed again, and then it has been at least critiqued, that reanalysis. So we don't know. And then the ECAS-3 was recently reanalyzed by Alper et al. And they also found that this was, I can't remember if neutral or negative, neutral or harmful. But so that shows that all 13 trials are either neutral or negative if we look at it from that perspective, right? And that's where the critique comes from in emergency medicine. Well, how can we give a level A recommendation to something that is not, that doesn't seem to like have any, like what we would in evidence-based medicine call good evidence? Then, of course, the Cochrane collaboration is this movement parallel to the evidence-based medicine movement from McMaster's University and David Sackett, but they have a lot of this like overlapping values. And historically, they didn't come from the same place in the first place. And the Cochrane collaboration talk about the meta-analysis, right? So if you do meta-analyses of all of these, then maybe even if the single studies are bad or less good or negative, then maybe there is a benefit anyway. You have you have what you call the forest plot, right? Like the sum of all these studies, where you pool, like a meta-analysis, where you pool all the studies together, and then you might be able to find a summarizing benefit, right? But for you to do that, you have to be hugely knowledgeable about not putting what you call the garbage in, garbage out argument. If you have a meta-analysis where you just pump up the numbers, get a lot of patients in, and take all studies in without thinking about the quality and weighing in stuff like that, then you will get what you call garbage in, garbage out. Ken Milne usually talks about if you make a good pie, then you need to have good apples. If you do use bad apples or a cow pie, like meaning a cow shit, then the pie won't taste as good, even if it's only one bad apple or bad study that goes into the meta-analysis. Then the outcome will be bad. Especially if that study is really good, really big, then that will weigh too much on the entire picture. And sometimes you can, the good Cochrane analysis will oftentimes like kind of put into this account. They won't put too much weight on those studies, and it will try to diminish their effects on the entire landscape of studies. But in general, a meta-analysis is only worth so much depending on how which studies they put in. And the problem with meta-analysis is that they have like this, if you need to pool all data like as if everything was one big study, you need to have kind of homogeneous outcomes on how much is everything. That's one of the other problems. There has been, so in the alteplase literature, there's also been made meta-analyses, 3 of those in the stroke literature, and I guess there's one from Cochrane, there's one from Emberson, there's one from Donaldson, and depending on which ones you use, it's kind of you can get different conclusions. So, for instance, the NNT for a couple of years ago, the homepage of the NNT, they did the conclusions from this one, and then it was green. Then their recommendation was green. You should use it. I think they started using this one, then it was red. They shouldn't use it, and now it's yellow. Done by Ken Milne and Justin Morgenstern. Like, we need more evidence, right? That's important to say emergency medicine's stance on this in general. If you or the foam literature, like the foam culture, stands on this, at least represented by Justin Morgenstern and Ken Milne, but not by Eddie Lang. To inform the inform the bioplausibility of removing a clot actually does help. Then I just wanted to show you this, like the embolectomy, kind of the same graph for that. That's much better, right? And there's nuances here as well. Check out the Rebel EM where I got this, like Rebel EM post, and also YouTube video where I got this from. Thank you, Salim Rasay. But in general, there's less controversy here if you do like choose the right patients. Like this is not all strokes. These are M1, M2 strokes, right? Maybe sometimes M3 strokes, but mainly M1 and M2 and some others, right? So it's a really selected group. But for these, here we found like a group where there is a definite benefit, right? So yeah. So the bioplausibility of removing the clot in some populations in certain conditions is important, right? So this is not an area we should just give up on. We should keep going. And this is what we need to know, like the background going into this study. So now we'll talk about like what about the minor strokes? This is from like all strokes, like and this is for like big strokes, what you call large vessel occlusions. But before the graph I just showed before, that was from all strokes, right? And it may be like there's arguments to be had that when you do average, like the study is average, right? You take both if you both take the like big strokes and you take the small strokes, and if it helps most on the small strokes but not on the big strokes, because that's where endovascular therapy works most, then you will then you will average out that, and then the average will be 0, even though there's a big benefit here and no benefit there. So there's definitely something like it's important to use some kind of like different subgroups to kind of inform, like before you're giving up on the therapy, definitely. And here we're looking at these, like this is a population that we see a lot of the time in my hospital, patients with, because the big strokes goes to another center, so we get all of these like minor or kind of hard to figure out strokes with NIHs below 5. And if we just wanted to look at the studies here, so far they haven't shown too much positivity. And in most of the studies, the strokes that have been ruled out are the ones that have like disabling strokes. And most neurologists would usually say, like the disabling strokes are the strokes where you have a hand. That like the dominant hand, especially if you're a working person, like a pianist or someone who works with your hands, or if you are aphasic. Those are usually some of the ones that are most disabling, right? So those are usually ruled out. So the ones that are non-disabling here, and these two studies are negative. You can check out a deeper dive on them on Brian Radecki's homepage. So we'll go out and we'll go in here with this PRISMS trial now to see what do we. This is the only RCT in this space. So we'll see what does it actually show, and how do we think about it. So with that is the background before going into the study, right? So where are we on our spectrum of pretest probability? Well, I mean, from a bioplausibility standpoint and on the evidence standpoint so far, I guess it's hard to say where we are. Some people may be down here, some people may be a bit up here, I guess, but I don't think there's anyone who's really up here and no one who's, there may be someone who's really down here, but I think most of us are somewhere in here. That's at least for me. That I'm kind of skeptical that it works. It may work, and I really hope it works, and there might be a subpopulation that we haven't found. But with strokes, ischemic strokes of NIHs below 5, I mean, yeah, we don't know, and we want to do studies on those because those are the ones that have the most to lose. All right, if you have a big stroke, then you have less to lose, sort of. You have a lot to gain. And I've made this graph from overdiagnosis in a lot of other videos, so check that out. But like if you have a syndrome, or if you have a disease that is in the mild spectrum, then you have more to lose from the therapy because the harms are the same, but the benefits are smaller. If you have a large disease, or a large or a severe disease in the spectrum, like a large visual occlusion, you have a lot to gain and the same amount to harm, right? You usually don't bleed that much more. So it's a truth with modification, right? But the benefit harm ratio is better with large vessel disease and then with smaller, right? Okay, so this is important to kind of figure out where we lie. We'll see. Before going into the study, before analyzing the study, I think evidence-based medicine and journal clubbing, it's much more important. And when you're reading studies on your own, it's much more important, these three questions, I think. And that's what Vinay Prasad says. It's what Justin Morganson also say. Like, the first one is, what is the question the study is trying to answer, right? So this specific, the PRISMS trial study, like, try to make a sentence out of it, and like oftentimes it's not the title, it's something else. It's like something you have to read through the methods and see what you think is actually trying to be answered. Sometimes it's not the same as the title. So I think in one sentence, this is the study that the question is that is trying to answer is alteplase superior to conservative management, meaning aspirin and all other stroke care, in the patients that have non-disabling strokes with NIHSS score of below 5? I think that is what is trying to be answered here. And the superiority is about neurological favorable outcomes, or meaning an MRS of 0 to 1. MRS score that is decreased by 1 amount. Right, so going from 2 to 1 or 1 to 0. And I think it's important to, what do I do in my clinical work for this particular question? Like, what do I do usually? What is my conservative management? Well, my conservative management is usually with these patients, if we don't thrombolyze them, then it's aspirin, 300 milligrams of aspirin, and we don't do DAPT unless it's specific specific conditions, right? So we don't do DAPT, dual antiplatelet therapy. And if it's someone who has atrial fibrillation, then the new timing trials has shown us that we can use NOAC or DOAC with a time delay of a few days, depending on how big the stroke is and so on. So yeah. So I want the study that I'm reading to be somewhat similar to that, and then I'm kind of admitting them to our stroke unit, because stroke unit care is highly evidence-based as opposed to a lot of other things, right? So whatever they do and whatever we do in stroke clinics, it's really important, and it may be unmeasurable on the specifics, but in the general, it's really important. So that's an important question to actually ask ourselves. What do we do? Because if the study is vastly different, then we can't really apply what we're doing. Oftentimes, studies would use much higher doses or lower doses, especially if a drug company wants the other drug to look bad or your own drug to look good, right? You kind of put the odds on your favor. That's done all the time, right? And so on. So and it's okay. So with that in mind, what would an ideal study of this question look like, right? How could we imagine an ideal study of this question? So my ideal study would be, it would be an experimental study, an RCT with patients coming in within 3 hours. That's where so if there is evidence, that's where the evidence is. I would probably do a perfusion CT, knowing what I know now, but maybe not in 2018. But that's probably what we would do now, right? To see if there is any penumbra left to actually be treated. And and then you will give placebo, and then you will blind people to the placebo or which arm they are in, and you will allocate them so that they, like, both the one group gets IV alteplase and the placebo, and the other group gets IV placebo and alteplase and aspirin, so that there's no there's good randomization, and then their concealment, so that they don't know which group they're in, because if they only got alteplase or if they only got oral tablets, then they know what kind of group they're in, even though they're randomized. So there needs to be concealment, meaning that they don't know which group they're in just by, like, if the bag is red in one group and is white in the other, then you kind of know that there's different groups, right? And so that's what concealment is, and that the other thing is randomization, right? So we want those things, and then we want to measure poos. So we want to do it in the population of everyone, right? And on the older patients, on all adults, the ones that we actually are treating. Wake up strokes, not wake up strokes, and so on. It might be part of a subpopulation, and so on. That might be an ideal study, just rattling here. But I think these questions are probably the most important, or this is where, because if the study that if the question that the study is trying to answer is not relevant for us, then we can discard it. If what we do is totally different than what the study control arm does, then it's not important to us. Or if the treatment that they're trying to propose to us, it's not something that is achievable in our setting, then it's not relevant for us, right? And if the way that they're doing their study, it's totally, like, they should be doing RCT, but they're doing an observational study, or they're doing something totally different, then that's also a problem, right? And how our ideal study looks like, I mean, if you're an expert epidemiologist like Vinay Prasad or Ken Milne or whatever, they can, like, detail this much more. But it's nice to, like, kind of know why. Like, we think the benefit is not huge, therefore we should do an RCT. We think there's equipoise, then therefore we should do an RCT, and so on, right? Okay, so now we go into the PICOS, and we look at the method section of the study, and we'll look at we do PICOS, and we check out the results. All right, so the population of the study is and here I did in Swedish, but it's it's 18 year or more. It's ischemic strokes with an NIHS of 5 or less, or below 6, and the symptoms are not invalidating, defined as symptoms that are, if they are reversed, will hinder the patient in if they're not reversed, it will hinder the patient in doing activities of daily living, such as bathing, mobilizing, doing toilets, like going to the toilet, hygiene, and so on. Neurologists usually talk about, like, if you're not able to wipe your own ass, then it's not a good outcome, right? That's usually where they draw the boundary on the MRS score as well. Oh yeah, about the MRS score, I forgot to talk about our ideal study would be with a POO, like patient-oriented outcome, like a mortality or morbidity benefit, and especially in neurological studies is important with neurological, like, good outcome. And ideally we would want another score that is more ideal than the MRS, because the kappa value is kind of all over the place. There's a subjective evaluation of it, and it's an MRS of 0 is like quite easy to find, and an MRS 5 is quite easy to find. But what really matters is the MRS score between, like, 2 and 3 and 4, because that's where most people lie, and that's where that's where a step down is really important. A step from 3 to 2, and especially from 2 to 1, because the boundary between good and bad neurological outcome is usually between 1 and 2. That's where you can and cannot wipe your own ass, as they say. Okay. All right, back to this. Then the decision whether it was an invalidating symptom was taken by the clinician together with their family. That's reasonable. That's what we do as well. But I would like there's no magical thing about having aphasia or having a dominant hand numbness or especially weakness. There's nothing like there shouldn't be more benefits to treating that. It's just that they will risk more. That's the thing. They will risk. They have a higher risk aversiveness because it's so important to them, right? And then they excluded the ones that had an MRS of 2 to 6 before, because that makes sense. You cannot become better by doing thrombolysis than you were before. And we kind of want to know when the ones that had a good neurological outcome, 0 or 1. So I guess that makes sense. And then dysphagia, yes. You cannot have dysphagia because you need to be able to swallow the tablets. Otherwise, you'll just get aspiration pneumonia. ICH, if they did have a bleed before, or if they have contraindications to TPA. And I guess like these are sensible exclusions, I would say. Then you give IV TPA then the intervention, and the intervention is here IV TPA within 3 hours from symptoms onset, and an oral placebo within 24 hours. And that's true. Like aspirin should be given within 24 hours. That's what the guidelines and the evidence says. So that's acceptable, and that's the same dose as we give. I cannot remember if the study says that how they give it. We usually bolus 10 milligrams, and then we'll get the rest over an hour. And of course, we have to treat hypertension, and we have to treat glycemia and so on, so that they're normal, like they don't have any contraindications. That's what they either ruled out or probably treated in this study. And if you wanted to go into details you can probably go into details with that in the study. I haven't, because I didn't do that deep of dive, but you can do that in the supplementals. Okay, then controls would be oral aspirin and IV placebo, and then you'll do this safety outcome thing where you have to do this follow-up CT scan as well. That's part of the what they do in the intervention and control group. And then you have the outcomes, and I guess the primary outcome is the most important, because as Ken Millen says, there can only be one primary outcome, and it should not be changed, even though a lot of the times it will be changed during the study time. It shouldn't be changed. And you can check on clinicaltrials.gov whether or not they've changed their primary outcome. Then we have a lot of secondary outcomes, and secondary outcomes are should be limited to a few, maybe a handful, not more, and should be relevant. And all of these are POOs, right? They're patient-oriented outcomes, and that's really good. And I'm not sure why they might be using a GIO, another score than the MRS, because they know that the MRS is not that good. So it's really sensible to I think, for my knowledge, it's probably really sensible to do this. Then they have this safety outcome, which is also really sensible. If they have ICH, right, that's a safety outcome. That's really good. That's why they do the CT scan, and they do a neurological follow-up. So that's the outcome, and these are POOs. And I guess in this part of the journal club, we don't interpret, we just give the data about this. We'll talk about what is good and what is bad later. And then the study, I usually do the S as well. This is an RCT, this is double-blinded, double placebo. And I just wanted to show you that I think they started out with like 900 participants or something like that, and then they came out to 350 down here, and then they excluded some. These are not the excluded. And then we look at the table 1. We'll look at it later as well, but I just show it now. The table 1 is really good to know whether or not the randomization was good, and also to know the population in the PICOS. Do these people look like my population? And they do. They do. Like it's mostly, at least in Sweden, it's mostly white. It's a lot of them have diabetes and hypertension. So that's the first question you can see in the table 1 in all studies, right? It's, do they look like my patient? And if they do, that's good. Then it's still like you can apply that to your own population in your own clinic. But the other thing is has randomization succeeded? And this is more like how different are the two groups in between each other. And besides a little bit more diabetes in this group, it's kind of similar. And that means that, well, everything else being equal, this group is maybe a little bit more sick, right? The ones who actually was given the alteplase. And that's important to have in the back of your head. Okay. Here's the result table. These are the important results. How many patients had MRS 0? 44 in 45 in the alteplase one, and 50 in the other one. It was, I believe, not statistically significant. And then here we have MRS score of 0 or 1 unadjusted, and here you see like these two values are like the confidence interval is crossing 1, meaning that these two values are not. They're really like they're the same. And here's the other outcome, the primary safety outcome. You have 5 bleeds in the intravenous alteplase group, and you have 0 here. And here, this is okay. So we're talking about statistical significance. If you think about a line being drawn in the middle here, then the first one, like the primary outcome, it was really like it was just a big fat confidence interval all across with the line in the middle, right? Yeah. But this one has a big trend, you would say, like a big trend towards this being a problem. And if only they had maybe one more, you can calculate probably a fragility index here. Then it would be statistically significant. And I've linked to a lot of pages talking about why statistically significant probably is overrated and we should not be using it as we are. But that's another thing. I'll just say that it's something that could be a little bit important, but we probably shouldn't use too much weight on it. So this seems like really positive, right? This seems like a bad thing, and that's So that's the results. And I just summarized, or Rebel EMS summarized this here. And you'll do that's the PICOS and then the results. And then we'll do the checklist to see whether or not we believe in the results. How good a study was this? Like how imprecise were these results, right? How biased are they, and so on. So you can do any old checklist. This is from the BEAM, like the best evidence in emergency medicine. You can get it from Ken Milne's homepage. And you just do these questions, right? The study population, and sometimes you can't answer them, and sometimes you don't know what the question is, and then you can listen to Ken Milne talk about it, and you'll know afterwards. The study population included or focused on the ED. Yes, it was stroke centers, but it was focused on the ED. The patients were adequately randomized. Yes, we saw in the table 1 that they were, and there was a little bit of difference in diabetes, but minor things. I think the randomization, it was good. And the randomization process was concealed. meaning that once you were in the group, did you know kind of whether you were in that group or not? And it seems like both got placebo and IV, and there wasn't anything to suggest that it wasn't concealed, right? Once where there isn't concealment would be, Vinay Prasad usually gives the example of the Bangladesh COVID mask study, where if maybe like where two villages or several villages were randomized, right? So one village was like cluster randomized. So one Now we're going into like more like interpretation and so on. So the strengths, Stugo here with your arms, and weaknesses here. So the strengths is this is a really well done RCT. It checks all the check marks. It's very close to what I do in my everyday clinic. It's very close to the ideal study to do for the question in mind. And it uses POOs, like it's patient-oriented outcomes. It uses MRS, but it kind of tries to like do secondary outcomes around MRS to see if it can compensate for the lacks of MRS. It's a really well thought out, well done study. Then in between here, like as I said, there's a loss of follow-up, but it's symmetrical, so it's not all bad. Yeah, but we don't know if they did it intention to treat or per protocol. Yeah, it's what it is. What it is. It's a minor thing, but it's important. This is the most important thing here. It was stopped early, and it says it was stopped because of slow recruitment, against the recommendation from the scientists doing it. Because the trial was terminated early by the sponsor for enrollment below target, it was recognized that the study Okay, so now we're going back to our Fagin's nomogram. We're kind of going full circle because now we have kind of now we have our analysis of our study, so we can kind of evaluate the likelihood ratio that we wanted to use here now. So if we do as this study, like the maybe the pharmacological company wants us to do, and maybe a purist would say like there's no statistical significance here, therefore we cannot use the study. Then we might consider like the likelihood ratio to be 1, no matter where we come from. It doesn't change our opinion. We should overlook this study. Well, I think most people would. Some people may say that. Most people would not be up here. I think it's definitely like it's not a positive study. It doesn't encourage us to do alteplase. The discussion is whether we're actually negative and how negative we are. Had the study been done to the end and it showed definitely harm, then it would be when we were down here, right? And then we'd be really like more certain. Because it was stopped early, and I guess the pharmacological company probably succeeded in this now, then even though it was masked behind like slow enrollment, then I think this is probably somewhere around here. It's something that I don't think it's neutral. I think it's like we are less certain. Like we're less prone to give alteplase after this study in this population. And then okay, so now we're going back to our case. Our 55-year-old man who was a concert pianist with a weakness in his right hand, dominant hand. And this patient may have been excluded in this study because they would say that maybe it's a debilitating injury. And as I said, the argument, I don't strongly think that these patients are any different than the ones that are considered non-debilitating. It's just that they want to run a higher risk. So this study, I would say, applies to this patient as well. Okay, this is the last slide. I hope you enjoyed this kind of broader walk through like some of the evidence-based, like the way of evidence-based medicine, but also the critiques of evidence, some of the critiques of evidence-based medicine, and as I think is more important, the critical thinking of it, and the way that we can look at the spectrum of epistemology, like mechanistically thinking experience, and also where the tool of evidence-based medicine has its place, but definitely should not be hyped above its status, and should definitely be critiqued, but also don't throw out the baby with the bathwater. Use what you can, but yeah, hopefully we'll get to a place where we can have a better way of doing EBM, and also doing guidelines. Okay. I'll end with this quote from Justin Morgenstern, who tells you how he would treat or tell his patients. I don't think he tells all of this to all the patients, but this is kind of the gist of what he would say. And he would say it like this: there is a treatment we sometimes use for stroke that is supposed to break down clots causing the stroke. The treatment is controversial, and you will probably hear different things from different doctors. And the issue is that out of 13 major trials, this is probably where he might not say this specific things, but only 2 have shown benefit, and both of these trials have some problems, and they were both paid for by the people who make the drugs. Yes. There are some risks that we are certain about. 1 in 12 patients, and that might be a bit high, maybe 1 in 20 patients will have severe bleeding results and worse neurological outcomes. Despite the risk, in the best case scenario, about 1 in 10 people given this drug early will have a noticeable improvement in their neurological function after 3 months. And yeah, and then you might, in parentheses, say that this subgroup that we looked at now is probably, they have more harm, and the benefit has not been shown. All right, the harms are probably the same, but the benefits have not been shown. And then it goes on to like say, unfortunately, it isn't clear how reliable the science is or has been, and we don't know which patients have the greatest chance of benefit and harm. The choice to receive this medication remains up to each individual patient. Yeah, so that's what he says, and I hope this is not something that has been talked a lot about in Scandinavia, I think, at least not in Denmark, and I think it's important that we kind of at least well, the main point is that we do maybe think about doing journal clubs, and we think about critical thinking, and we think about like how big or small these benefits are in the studies, so that we can focus on maybe something else. Then the things that, like the discussions on these things, but maybe go on to talk about compassionate care or something that may even be of bigger benefit for the patients than these things. And the best thing would be in synergy, to do it in synergy, and to make EBM better, right? So that we can use it as it was intended, with regulations and FDA and EBA and the EDA, the European organization, becoming better at the regulation. All right, I think that's it. Thank you so much for listening in, and I'll end. I hope I didn't discourage you from doing thrombolysis. I think there's definitely, do follow your local protocol, but have this discussion in your group. It's a good discussion to have, and it's a good example of evidence-based medicine and how to use it and so on, and maybe what are the weaknesses as well. And yeah, I'll end with that. Thank you so much, and bye.